and we'll go ahead and have some questions for you. The first question is, can a pinched nerve in the neck cause numbness in my hands?
Yes. So if you remember that dermatome map that we saw earlier, a problem at for instance, the C6 nerve root can cause a problem with the thumb or the pointer finger. It can cause pain to radiate down. And sometimes there's compression in the neck, but there also could be compression in the elbow or the wrist. If you think about a nerve like a pipe with water in it or a hose, the garden hose can be compressed in the neck, and it can also be compressed downstream from that. And the combination of compression in both places can cause pain, numbness, or tingling, or weakness.
Great. We have another question. What do you see as the determining factor in choosing fusion over laminotomy?
So it's a pretty complex question. One determining factor that we just spoke about in terms of the discussion that we had is if a person has a actual instability in the spine, it's really not indicated to do just a laminectomy or a microdecompression without fusion. When you take away ligament, even if it is arthritic and pathologic, that can cause that instability that's already present to become worse. If it's just an acute disc herniation without a problem with stability, if a person has primarily symptoms that occur when they're standing or walking, that can be just laminectomy alone. It is a case-by-case basis. We look at multiple different factors.
Very good. Next question is, how do you feel about nerve ablation to relieve pain?
So nerve ablation is good in very specific circumstances. If the person has facet-oriented pain, they've had a medial branch block, and after getting the medial branch block, they have excellent relief of the axial back pain, which is back pain just in the axial skeleton, a radiofrequency ablation is good. If a person is doing radiofrequency ablation to try to alleviate radicular symptoms going down the buttock or the leg, the anatomy doesn't work that way. It usually does not work.
Great. I'm not sure I can pronounce this one, but the question looks like, how do spondylolithisis and retrolethesis differ?
They don't really. So it's talking about the direction of the slip. A spondylolisthesis can also be called an anterolesthesis, which means that the slip is moving forward. A retrolesthesis means that that bone, that reference point, is moving back.
Okay. The next question is, will the lumbar surgery help me with my bladder and bowel problems?
So it really depends. Some people have bowel and bladder problems because they developed a Athanassious syndrome. That's something that needs to be treated right away within 72 hours or less. If it's a problem where the pain in the back is so severe that a person cannot empty their bladder and they're feeling like they need to go, or when they need to go immediately, that can be something that may be helped with bowel and bladder. What I would recommend is seeing me, and also we can correlate that with the urology evaluation to take a closer look at that problem.
Very good. Next question is, if I have degenerative disease in L4 and 5, but little pain, how often should I be x-rayed and examined?
So I would say that it's not something that you need to come in just to be x-rayed. I think that you should get a baseline, come and see a spine specialist, have them take a look at you, do an exam. Then after that, we can educate you on what to look for and when to come back. It's not something as a matter of every year you need to come in, or every 5 years, or every 6 months. It's really understanding what to look for and to know when to ask for help.
Great. Our next question is, if one has contact pain on one side of the neck, stiffness but no headache, how do you ask for an x-ray? My PT says I should ask.
Yeah, so you just ask for the cervical spine films. We would get a front view and a side view, and sometimes we'll take a look at what we call flexion extension views to see how the neck dynamically moves. Another way of looking at things is just to get that for those first 2 views and see how things look. The surgeon will take a look at it, or I could take a look at it. We have x-rays in our office. If I need more, I can get more. You don't need to worry about getting x-rays before you come in. We have x-ray in our office.
Very good. Next question is, can sleeping on an elevated bed used for acid reflux cause neck and back pain?
Sure. There's all sorts of cases where patients will have a change in mattress, have a different pillow, have surgery and have to sleep in a different way, or have surgery and have to walk a different way. And now that is throwing off their spinal balance, causing irritation in the nerve roots, and that's bringing possible problems that were actually present in the spine earlier but weren't brought to light because there wasn't this different way of sleeping, different way of walking, or change in balance.
Great. Can pinched nerves and stenosis cause cramping of your legs, hands, and feet?
Sure, of course. Stenosis is a simple term that means narrowing. So if you imagine if there's narrowing anywhere in the cervical spine, that can cause a problem in the hands or the feet. If there's narrowing in the lower back, that can cause a problem in the lower back or down the legs.
Good. The next question is waiting for a laminectomy as my age increases a problem? My pain is fairly minor at the moment, but I'm 75 and a type 1 diabetic.
Mm-hmm. So I would encourage you to come in to be evaluated and to be looked at. Not everybody needs surgery, but it's good to keep an eye on things and to watch how things go. I always tell patients, you're the youngest you are today. So we need to evaluate what's the impact on your life and what kind of surgery will we need to do and what does that recovery look like. Constellation of those factors brought together help us make a decision. And together, you and I help make that decision with me educating you the best that I can and answering the questions and getting a feel for how much this is affecting your quality of life.
Great, thank you. The next question is, I have osteoarthritis in my back and neck with clicking. What do you suggest?
So if it's not with pain, it's a difficult thing to truly evaluate and treat. What I tell most of my patients, if the clicking is painless, I really wouldn't worry about it. We can, of course, get x-rays. We can be educated on it, but nobody's going to do surgery because there's some clicking in the neck. The chance of fixing that problem, the risk and benefit is not great.
Great. Next question is, how do you make an appointment and how far out are your openings?
So I think that we are scheduling a few weeks out into July right now. You can call my office. You can fill out the survey afterwards, and we can reach out to you. We're happy to do that.
Great. Next question is, what is spondyliosis?
So spondylosis is just a simple garden variety term that describes arthritis in the spine. It can be the arthritic facet joints that we talked about. It could be the degenerative disc that we're talking about. It's another way of expressing arthritis within the spine. So when you say that a person has lumbar spondylosis, it's just a garden variety arthritis within the lumbar. It can be in the cervical spine or in the thoracic spine.
Very good. The next question I can actually answer, and it's, will this recording of the program be available for review? And the answer is yes. At the end, there's a survey. So just make sure you take it and put your email address in there, and we'll get you out the link to watch Dr. Athanassious' presentation again. All right, our next question is, I have a sleep number bed. Should I keep the legs down after surgery?
Down after surgery. I would tell you to keep the legs in whatever position is most comfortable for your back to get you your sleep. It's really important to get sleep after surgery. We know that people that are sleep deprived have a sensation, the same pain sensation that comes from the back or surgical site will feel to us much more painful and much less manageable. So whatever position is most comfortable for you, I would recommend.
Great. Our next question is pregnancy often a cause of sciatica?
It's not often a cause of sciatica, but pregnancy releases different hormones, which causes a kind of laxity in the ligaments across the body. It also causes an increased amount of fluid retention. So we often hear about people having sciatic symptoms or carpal tunnel, for instance, during the time when they're pregnant. Additionally, the increased baby weight does throw off the spinal balance, and it can last past the term of the pregnancy.
Great. Next question is, I have been seen by you and a laminectomy prescribed, but can you cure this without surgery?
There is, if it is spinal stenosis, it is unlikely to actually have a long-term durable treatment without actually surgical treatment. We know that if problems are not fixed or don't resolve themselves in about 6 months, and really on the high side of that, a year, they're not going to be fixed on their own. And the most likely thing is the pain will continue and most likely get worse over time.
Okay. Next question is, do you do QME exams for work comp cases?
I do not do QME. I will do a what we call a permanent stationary evaluation, but I do not do QMEs at this time. You need to be certified for it, and I haven't taken that certification.
Thank you. Next question is, what is severe degenerative arthritis in the facet joints?
So the facet joints are smooth. If you think about joints, they're usually very smooth surfaces with a small amount of liquid inside. Severe facet arthritis is speaking most likely about that smoothness not being there, and also a deformity or enlargement within the facet joints. That can cause axial back pain. It can also, if it's large enough, cause spinal stenosis, which is that feeling of pain radiating down the legs and tiredness when a person walks. It can also cause radiculopathy, which is the pinching of the nerve as it exits from that neuroforamen or nerve hole that we spoke about.
Great. Our next question is, does your clinic have physical therapy modalities?
It does. Our Mark West office on the 3rd floor of the Sutter Medical Office Building has extensive physical therapy modalities that are very good at all musculoskeletal treatment and are very well versed in spine physical therapy, pre-op, post-op, and just treatment of back ailments. We have PhDs, we have people with a master's degree, and we have bachelors of science all in the same building there.
Very good. Next question is, my mom has a disability and doesn't understand some things. Would I be able to be there before surgery to help with any questions?
Of course. Right now during our COVID time, I'm happy to call patients and put them on speakerphone, and we can of course do a case-by-case basis in situations like this.
Great. Any enriching diet you recommend for back, bone, spine health? Question.
There is no special diet. I just tell all my patients, make sure you have a well-balanced diet, use a multivitamin as you get older. And that's not just for spine health in terms of arthritis, but in terms of trying to protect the best we can against osteoporosis and problems with age.
Okay. Next one is, I'm 74 years old. For occasional lower back pain flare-ups, is it okay to take approximately 1,000, I think it's probably milligrams or grams Tylenol and 1,000 ibuprofen for several weeks? I have no GI side effects. My primary care doctor is concerned about kidney and liver damage. Should I worry?
So that's really up to your primary care doctor to continue to take a look at your labs. Over a few weeks, and I don't know all your health history, should not be a problem, especially if you don't have liver or kidney disease. But we know that anti-inflammatories can cause gastrointestinal problems. They can cause problems in terms of raising blood pressure, and that needs to be carefully looked at.
Thank you. Here's another one. What is the cause of weakness in a thigh if one stands still in one place for more than a few minutes? Walking alleviates that alleviates that discomfort immediately.
So it's very hard to give you an answer exactly regarding that. It can be foraminal stenosis, which is that nerve hole pain. So most people, when they stand, they kind of lift up their head. They actually have pretty reasonable posture if they're standing in place. When they walk, they kind of tilt forward. They open up those the neuroforamen by tilting forward, and they feel like the pain is alleviated. So a lot of people say, I can't stand in place. I can't sit in any place for too long. I have to get up and move around. It's because of that standing and that slight tilt that you have when you walk.
Okay. Next question is, it's been 1.5 years since my last MRI and I have not improved. Should I get another?
I think you should have me take a look at it, or another spine surgeon take a look at it, and we'll decide. We need to evaluate you. We need to see how things have not improved. Have they truly just gotten worse? Is there worsening in terms of your physical examination symptoms? And that'll give us an idea. We can also get x-rays and compare the x-rays that you have in the office to your older MRI to see if there's been much change.
Great. Thank you. Next question. Thank you for all these good questions, by the way. Next question is, realizing that walking is good to help back issues, what do you do if it hurts too much to walk any distance? Should I consider taking a pain medication just in order to walk?
So that's pretty reasonable, but I would definitely recommend you come in and you have it looked at. That's a very typical presentation of spinal stenosis. That presentation is called neurogenic claudication, which means nerve pain when walking. And it is a very common thing that we treat. We treat it with the modalities we talked about: physical therapy, epidural steroid injection, and even just an overnight procedure. And often what I hear from patients after they've suffered with these kind of pain for years and years, that they wish they had done it years previous.
Here's another good question. For somebody who has 25 or more pounds overweight, would losing the weight help alleviate back pain?
So we know that loss of weight will help with back pain problems. It may not be the only problem that is, there. Of course, losing weight will take pressure off of the core muscles, will allow a person to have less pressure on the discs. But there may be a constellation of symptoms in addition to obesity or increased weight that can cause back pain.
Great. Another question. Are there other options without surgery? Steroid shots, anything else you recommend?
Sure. No, all of those are all steps along the way to the appropriate treatment for your back. When we take a look at, and I kind of alluded to this earlier, patients come in with multiple different problems. There's many different ways to address that problem. Some patients are okay with a certain amount of discomfort, even a certain amount of numbness or weakness. They can live with that. And we kind of guide that. And if we get that sense from our patients, we educate them, and we give them a treatment modality that is appropriate for them. Some patients are very bothered. They're very active, and they need a better functional outcome. Those patients may require epidurals, or they may require surgery. It all depends on what the quality of life is, what the expectation is, what's the patient's general medical history, and what is the likelihood that we can give a person a very good outcome with just physical therapy or epidural injection or surgery.
Great. Next question is, can you do anything for spina bifida? There is also spondyliosis and degeneration L4 and 5.
So most likely the spina bifida is not the cause of your pain. Those other pathologies that you named definitely could be. So we need to take a look. I probably would not do something with spina bifida alone, but if those other modalities are causing a problem, there can be many treatment options.
Next question is, what are your best recommendations for stretching yoga and Pilates and weights?
So I don't really have recommendations regarding that. What I encourage my patients to do is kind of discuss with the physical therapist, what are the activities that you enjoy doing? And the physical therapist can help tailor those activities, those stretches, to be something that can be done at home on a frequent basis and that can be maintained over time. And the physical therapist has a little bit more knowledge in terms of those kind of activities, and has just a good amount of time to be able to look at a person's musculature, how they stand, where they're weak, and be able to address those concerns.
Great. Next question is, would my post-op surgical care be easy for tending to by my daughter?
Yeah. Yeah, we have many people that don't have anyone at home. They go home and they convalesce by themselves. We make sure with every patient that they're able to walk, get in and out of their house, do their activities of daily living before they go home.
Right. Here's another question. What does tingling in your leg mean?
Yeah, so it can be this spinal stenosis term that we keep referring to. It could be within the center canal, or it could be out the nerve hole. We'd have to take a closer look with x-rays and MRI, but that's certainly, if it's radiating symptoms, if a person has back pain, it can certainly be coming from the back.
Great. Here's another one. Can physical therapy be done out of office?
Oh yeah, for sure. So what I tell all my patients is that physical therapy is not something that's meant to go indefinitely. You go 1 or 2 times, you go home and you do the exercises, you get good at those exercises. You go back to physical therapy, you get more fine-tuning, more exercises, and you progress your care. And eventually, you don't need the physical therapist. You know what to do, you know what works for you, and you do that on a daily basis, and you keep your spine health up.
Great. And this next one is, what kind of massage would you recommend for flare-ups and or maintenance?
So there's no recommendation of massage. It really is what feels good for a patient. I do ask patients to kind of hesitate away in any strong manipulation of the cervical spine. But if massage therapy works, if acupuncture works, if chiropractic care works within the lower back, it's not unreasonable to try it.
Good. What can be done for neuropathy?
Lots of things. All of those things that we talked about. People are diagnosed with neuropathy by maybe an emergency room doctor or a primary care doctor, and they can sometimes be from the spine, but they can be sometimes from other medical problems. A B12 deficiency can cause neuropathy. Diabetes can cause neuropathy. So we'd have to look and see. And once again, we take a look. We look at what the complaints of the patient are. We look at the x-ray and the MRI findings. We think about our physical examination. We listen to our patients, and we bring those all together. And when those line up, our ability to treat the patient and have predictable, reliable, excellent outcomes is increased.
Very good. Next question is, do facet joint injections or ablations do much good? And is there a serious risk to doing these interventions? Over time, does the injection material cause its own damage to the areas? Or if not done too often, is the damage not a serious concern? How often is too often?
So I would encourage you to speak to your pain management doctor about that. That's usually the person that does facet injections or radiofrequency ablation. The risk is not high with these procedures. These procedures are especially good for treating facet-related axial back pain. However, if a patient has neuroforaminal stenosis, central canal stenosis, degenerative disc disease, spondylolithic, the treatment modalities are not as great and they do not work well because the anatomy just doesn't make sense.
Good. Next question is, as one ages, can cervicogenic headaches, dizziness be reduced or prevented? What scenarios would qualify for surgical intervention, and what might be done in this regard?
So for my patients, I make sure once again that the history, their complaints are relating to the x-ray and the MRI. I look for physical examination findings such as weakness, numbness, or tingling in the upper extremities that correlate. And we talk about what are the chances that a person's headaches will be relieved from a cervical procedure. And we sometimes will do a diagnostic and therapeutic epidural steroid injection in the cervical spine to see if there's any relief of symptoms, even if it's for a short amount of time, to better be able to predict what surgery can do.
Good. Here's another good question. As a person gets into their 70s, 80s, and 90s, is there a point at which even daily stretching, moving, or physical therapy can't prevent the type of chronic neck and or back symptoms that bring patients to doctors?
No, I mean, everyone is different. Everyone has different genetics. They have different life situations. They maybe worked in different professions. And all of those things come into play. Some people will never have to see a back person or spine person, and they don't even have back pain. Some people are not as fortunate, and the stretches and daily exercises don't work in the long term.
Great. Next question is, please speak to the use and safety of ibuprofen and extra strength Tylenol, 500 milligrams, in a combination treatment of back and neck pain for patients who do not have adverse reactions to those drugs. What are the maximum dosages, length of use, monitoring, etc.?
So I would encourage you just to, because every anti-inflammatory is different. So I would ask you to look at the back of the anti-inflammatory and make sure you're not going over the maximum limit. If you don't have kidney disease or liver disease, it's pretty safe to take these medications. Also, if a person doesn't have a history of ulcers or gastrointestinal disease or bleeding, it's probably pretty safe to take these medications. All of these medications really should not be taken more than 2 weeks to a month. If they are, the reason for the back pain needs to be evaluated. In terms of Tylenol, this is cleared much differently. It's cleared through the liver. I encourage patients to take less than 2,500 milligrams a day. The real limit is about 3,000, but I want to keep it far below that in order to keep patients safe. Once again, if a person has pre-existing liver disease, it's not indicated and not good to take these medications in the long term. And once again, as with the anti-inflammatories, if a person is finding that they're taking this for 2 weeks, 4 weeks worth of time, they need to come in to be looked at.
Good. This next question says, the good doctor, I'm assuming that's you, diagnosed me with severe spinal stenosis. After 2 bilateral epidurals with Dr. Yang, there is a good relief, but it's not complete. The question is, will spinning on an exercise bike worsen my spine? It certainly helps with the heart health, but I'm trying to avoid surgery.
It's not going to worsen your spine. In fact, it probably feels better. That hunched over kind of posture that on a spin bike or a stationary bike is actually opens up the spinal canal and probably allows you to spin much farther than you would be able to walk.
Great. Next question is, do certain joints in degenerative disc disease, cervical and or lumbar, have a higher observation hotspot? Are certain ones likely to regress than others?
Observation hotspot? Can you just read it one more time?
Sure. It says, do certain joints in degenerative disc disease, cervical and or lumbar, have a higher observation hotspot? Are certain ones likely to regress than others?
It's kind of hard to understand the question. I would tell you that the most common levels that have disease in the cervical spine are C5 and C6, and the most common levels that have disease in the lumbar spine are L4, L5, and L5S1. I'd encourage a little more clarification, or come in and I can definitely answer that question.
Yeah, and I'll also say that you can, when you have the survey that pops up at the end of this, just type in the question and Dr. Athanassious will get back to you. Another question is, what do you think of meloxifene as an anti-inflammatory?
It's fine. And once again, I just don't ever prescribe these things for more than a month without a serious look at what's going on.
Right.
These are not meant to be long-term medications that are taken for a lifetime.
Another question is, after surgery, how often should I go for a walk?
As often as you feel you're ready. If you're one of my patients, get walking.
Another question is, does itching have anything to do with leg tingling?
People feel it differently. Itching is not the most common of complaints that people associate with the spine, but I've heard all sorts of ways that we perceive this kind of compression on our nerve roots.
Next question is, I am over 65 and assume there is degeneration in the spine that's just a fact of life. Is the pain and tingling, feeling close to the surface, felt in the band of tissue that runs straight down the center of the lumbar sacral spine, likely posterior spinosis ligament? Did I get that right?
It's probably, that could be part of what's causing the narrowing on the spinal canal if you have spinal narrowing. Arthritis is a constellation of symptoms, and the spine has multiple different bones with multiple different joints at each level. The posterior longitudinal ligament is one of those ligaments that can thicken and can cause spinal stenosis and pain.
Good. Here's another one. As one ages, can anything be done about the thickening of the ligament, this ligament, and can surgery be an option for this if there's no stenosis showing on MRI or radiating pain into the limbs?
Sure. There's definitely treatment options. We'd have to look at that unique case and take a closer look. But yes, that thickening that you're talking about is a very common ligament called the Ligamentum Flavo. It is often thickened and stenotic in patients that are suffering from spinal stenosis and describing the symptoms of neurogenic claudication.
Great.